Hello, everyone. Welcome, and thank you for joining the 16th webinar in our Pandemics and Society series. Today's webinar topic is Mpox, a public health emergency of international concern. Today, we will be discussing Mpox and steps we should prioritize to address this global emergency. I'll now pass it to our moderator, Jennifer Nuzzo, Director of the Pandemic Center and a Professor of Epidemiology at Brown School of Public Health, to begin today's conversation. Dr. Nuzzo?
Hello, all, and welcome to our discussion. In August, Africa CDC and the World Health Organization separately declared that a rapid rise in Mpox cases constituted a public health emergency. This is not the first emergency declaration for Mpox. In 2022, Mpox gained global attention when cases and outbreaks began occurring in non-endemic countries across Europe, North Africa, and other regions. These outbreaks, which were caused by a specific clade of the virus, clade 2, marked a shift in the traditional geographic distribution of Mpox cases, which had historically been concentrated in Central and West Africa. In response, in July of 2022, the World Health Organization declared Mpox a public health emergency of international concern. This emergency declaration was ended in May 2023 after many of the affected countries were able to reduce the spread of Mpox virus clade 2. But while the emergency declaration ended, the public health threat of Mpox definitely did not. And in the last year, there's been a rapid increase in Mpox cases caused by a different clade of the virus, clade 1. The majority of clade 1 cases have been reported by the Democratic Republic of Congo and other countries on the African continent, but cases are now turning up in other regions of the world. These more recent cases, clade 1, may be showing different epidemiologic characteristics than the 2022's clade 2 Mpox virus outbreaks, including concerns about increased transmissibility and increased severity. And with this latest emergency declaration, there are lots of questions about the ongoing risks posed by Mpox and important questions about how to mount a globally coordinated and effective and equitable response to the virus now and in the future. And so there's lots of questions, and fortunately to help us answer these questions, we're joined by two globally recognized experts on this topic. We have Dr. Placide Mbala, who is Associate Professor at the University of Kinshasa School of Medicine and Head of the Epidemiology and Global Health Division, the National Institute of Biomedical Research in Democratic Republic of Congo. We're also joined by Dr. Christy Hudson, who's Senior Science Advisor for the Clade 1 Mpox response and Chief of the Pox virus and rabies branch at the U.S. Centers for Disease Control and Prevention. So thank you both for joining us today. We're going to start out with a few kind of questions that I'll moderate, but I very much encourage those who are participating to use the Q&A function and start asking your questions in that box so that we can answer them in a bit. And based on how many questions in there, I will turn to that sooner or later. But if we could just start maybe first with you, Dr. Mbala. You wrote a really important review of the Mpox outbreak in DRC, which is a country that so far reported the most cases of clade 1 to date. I'd love it if you could kind of give us an overview of what you're seeing in DRC and maybe just kind of your kind of level setting on what we know about the most current outbreaks associated with clade 1. Kind of what are the high level epidemiology points that we should be aware of so that we understand the current outbreak?
Thank you so much, Jennifer, for the floor. Yeah, I think
we don't see you, so I don't know if you are able to pull your camera on. So, good, wonderful.
Sorry. Yeah, so I've been working on Mpox since 2007. So I have the chance to see many patients and also to follow different outbreak of Mpox in the country, and also work closely with the CDC, USAMRIID, and UCLA on a different Mpox project in the country, and also recently with the NIH on the clinical trial. So I've been close working with our Minister of Health and the National Program of Mpox on the response of different Mpox outbreak. And what we observe in the country is a I can say significantly, a significant increase of Mpox cases, mostly in 2023. We believe that is probably due to the fact that people pay more attention to, with like the surveillance that become more sensitive after the global outbreak. But it's also the fact that we see kind of a new transmission dynamic with sexual transmission and sustained human-to-human transmission, and with the new clade 1B that emerged at the eastern part of the country. So right now in DRC, we are still having cases, more cases, more than 25, I can say, thousand suspect cases this year, with clade 1A reported, I can send more prevalent and more reported in the country at the west, and expanding to some other place of the country where we have never reported case of mpox, and also with clade 1B mostly at the eastern part of the country, like South Kivu, and expanding to also North Kivu and other neighbor countries at the eastern part of DRC. And also now we are having some cases popping up in other countries outside of the continent. So, and we have also this now new situation of a co-circulation of clade 1A and clade 1B in Kinshasa, which we believe that can be driven by mostly like a close contact and sexual contact. So we are here facing this new kind of situation with mpox, where we have this clade that we used to see in the country, which is now showing also some new transmission routes, like the sexual transmission, and this new clade, like the clade 1B that emerged recently, which seems to be more adapted to human-to-human transmission, and also could be transmitted through sexual activity. So this is where we are, and this, I think, is adding more complexity to how we need to strategize in terms of outbreak response and even case management.
Thank you. That's a very helpful kind of summary of what's happening. Maybe turn to you, Dr. Hudson, to see if you have anything to add in terms of kind of you've been tracking this global situation, and also if you have any kind of easy explainer for us in terms of what we know about clade 1 versus clade 2 and the subclades. Yeah.
Thank you, Jennifer, and thank you for inviting me here today. I think that Dr. Mambala covered it quite well. The only point I will add is that we do think that part of the reason we're seeing a big increase in cases is due to waning immunity. So smallpox eradication obviously occurred back in 1980 for the world. And to do that, there was a massive vaccination campaign. And of course, variola virus caused smallpox. It's an orthopox virus that's closely related to monkeypox virus. And so vaccination through that campaign did protect people against other orthopox viruses, such as mpox. So since that eradication campaign has stopped and there's no more vaccination occurring on a regular basis, in these endemic countries where we know mpox is maintained, there is not regular vaccination that's been occurring. So you have a very large population now that has no immunity or waning immunity to orthopox virus infection. So in addition to increased surveillance and some of the other things that Dr. Mambala mentioned, this is probably also contributing to the increase in cases. For just a quick overview of the two clades, which we've all heard a lot about in the recent news reports, and because of this drastic increase of cases in the DRC, this is not a new virus. So the first human case of mpox was actually identified in the Democratic Republic of Congo back in 1970. So this is a virus that unfortunately the country has been dealing with for many years. And we do know that there are two different clades. They're sort of genetically distinct from each other and geographically distinct. So clade 2 is found in West African countries, including Nigeria and Ghana and some others. And then clade 1, of course, is in the DRC as well as Republic of Congo and some other Central African countries. Interestingly, they're both found in Cameroon, but we've never found co-circulation of clade 1 and clade 2 in an endemic country. And so the hypothesis is there are certain geographic barriers in Cameroon that separate some of the animals that are likely reservoirs of this virus. And so we think that probably those geographic barriers have led to circulation in these reservoirs that has resulted in this genetic separation of the two viral clades. They're still more than 95% genetically the same. So clade 1 and clade 2, very, very closely related. Historically, for clade 2, we've thought of that as causing less virulent disease. And of course, that is what led to the 2022 global outbreak. And we're still seeing cases from that global outbreak, both in the US and internationally. And then clade 1 is associated with more people having more severe disease. There's some historical studies back from the 1980s that had a mortality rate of up to 11%. There's a lot of caveats with those studies because we don't know what the immune status of the individuals were. We don't know if they were all actually confirmed to have mpox. But in recent studies, we have seen case fatality rates more along the lines of 1.4 to 1.7%, particularly if basic healthcare is provided, including in one of the studies that Dr. Mambala has helped to lead, looking at TPOXX. So it seems like it's probably lower than what we historically have thought, but still higher than clade 2, which is generally associated with 1% or less mortality. And I know that we'll talk more about clade 1b, which of course has been in the news a lot, and that's what's spreading on the Eastern Front. But that one actually seems to have a lower case fatality rate than the 1a subclade. And so consistently, we're seeing less than 1% case fatality rate with the 1b isolate, probably multiple factors contributing, and happy to talk more about that later in the session. Thanks.
Thank you. So this next question may be basically asking you to kind of restate what you largely just said, but I'd love to get the two of you just to weigh in specifically about how much we know and the certainty around the differences between these two clades and severity as well as transmissibility, in part because if some of the observations hold, that could prompt, and then also crucially, populations that are at greatest risk of contracting the virus as well as at greatest risk of experiencing severe outcomes. Because understanding these differences could point to perhaps mounting a different response than perhaps taken in the 2022 outbreaks in terms of responding to it. So I'd love both of you, and maybe we could start with Dr. Mambala to offer his thoughts on this. Sort of what can we say about differences in terms of the populations that are experiencing infection, experiencing severe disease, differences in severity and transmissibility between clade 1 and clade 2. And if we could get some real clarity on that, then I think that will better inform our conversations about what we need to do, and perhaps if we need to do things differently than done in 2022. So I'll start with you, Dr. Mambala.
Thank you, Jennifer. So what we observe, because it's the clade 1b emerged as recently, and we are still gathering data for this new subclade. So with the preliminary data that we already have, we observe that at the beginning of this outbreak in South Kivu, we had more young adult, so adolescent and young adult affected, with a more, I can say, about 30% to 50% of sex worker are affected. And now we are seeing in some other health zone like Nyangezi, Uvira, Mirezi, some more children also affected. And as you may know, in Burundi also, where we have the clade 1b outbreak there, we have about 51% of children affected. So we see this kind of dynamic with the outbreak starting with the the clade 1B starting mostly with young adult affected mostly through sexual and close contact transmission. But in some places, we are also seeing children affected. And for clade 1A, we have more children under 15 years old affected. And then in terms of severity, we have more, I can say, severe cases among people affected by clade 1. I think with clade 1A, even for clade 1B, we have cases with more, I can say, a lesion and severe cases, but it's more with the clade 1A. And we observe about, I can say, the mortality seems higher with the clade 1A, where we observe about like 2 to 6% of case fatality rate compared with 0 to 0.7% for clade 1B. And also in terms of transmissibility, we observe after the genomic analysis more, I can say, a big mutation that maybe can express the fact that this clade 1B could be more adapted to human transmission. And this is also what we are seeing at the eastern part of the country, where we really don't have evidence of zoonotic transmission, but we have more sustained human-to-human transmission compared to where we see cases of clade 1A at the western part of the country, where we also observe many cases of introduction of spillover from the wildlife to human, and also some cases of human-to-human transmission. So this is what I can say about the two clade, the differences that we are observing according to data that we have until now.
Dr. Hudson, anything you'd like to add to that?
Yes, I will add some, but as Plessy just mentioned, there's definitely still data that needs to be gathered and assessed. For populations most at risk, again, for the clade 2 outbreak, and we continue to have cases, we continue to see deaths in those that are severely immunocompromised. So in the US, that's mostly those with uncontrolled HIV. For the clade 1 outbreak, it really depends on where you're looking in the country. As Dr. Mambala just mentioned, you sort of have different demographics on the eastern side where clade 1B is compared to clade 1A, where children are more impacted. Certainly, really major issues with food security in some of those areas for children. So those that are malnourished, you have measles, you have malaria. So all of these underlying issues are going to contribute to the case fatality rate, and particularly in the children that are impacted, that seems to play a big role in having more that have severe disease. You asked about genetic differences for clade 1 and clade 2. This is actually something that investigators, including my lab, are still trying to understand. They are genetically very similar, but these are actually very large viruses. They're almost the size of a bacteria. So there's been previous studies looking at the genetic markers, and it seems like there's multiple genetic reasons for the differences in clade 1 and clade 2. One of those is likely the complement control protein, which is a gene found in clade 1, but not clade 2. And that gene has actually been deleted from the 1B isolates. So in clade 1B, you don't find that CCP gene. And we do think, based on previous animal studies, that gene contributes to the increased virulence we see in clade 1. So that's probably part of why we see a higher case fatality rate for clade 1A than 1B, although certainly not the only reason. But likely there are other genetic differences that are contributing to the increased virulence in clade 1. For transmission, we base a lot of that on animal studies. And so our group has found that usually the animals have a viral sort of progression that is quicker for clade 1 compared to clade 2. So it might be the virus is able to evade the immune response during a clade 1 infection more efficiently than a clade 2 infection, and you see higher viral loads in clade 1 infected animals. Now, this is animals, and of course, that doesn't always translate to humans, but it's a really complex question, and we're still working on the answer. I did see a question about the APOBEC3 mutation, which Dr. Mambala did mention. So those are the same mutations we saw during the 2022 outbreak. And really, this is telling us, so that's a mutation caused by a human enzyme. And so as the virus is transmitted human to human, you see accumulation of those mutations. So we generally view that as a marker or an indicator that sustained human-to-human transmission has occurred. It doesn't necessarily mean that the virus is mutating to become more transmissible. The human innate immune response is putting pressure on the virus as it's spread human to human. And interestingly, you know, when we think about transmissibility for clade 2, although we have more than 30,000 cases in the US and they have these APOBEC3 mutations, 95% occurred through sexual transmission. There were very few cases that occurred due to household spread, even with people living with those with clade 2 infection. So it doesn't really seem to increase transmissibility as far as the APOBEC3 mutation.
So that actually raises a number of questions for kind of prospects for controlling the most recent cases that we're seeing. So maybe Dr. Mambala, let me turn to you in terms of what is needed now in dealing with this most recent public health emergency of international concern, focusing on the countries that we've seen this Mpox showing up recently. Take your point, fair point about increased surveillance, but just what do you think is most needed right now in terms of responding and controlling? Are there any kind of unmet needs in particular that you want to call attention to? And then after we talk about that, I think I want to talk sort of like the larger strategy, sort of assuming based on what I'm hearing from you both in terms of these trends, that this is probably not a virus that's going to go away anytime soon. And so how do we have sort of a maybe longer term strategy for dealing with this? But first, if we could kind of just very focus on kind of the here and now and what the affected countries most need right now. Dr. Mambala.
I can say that there are a few points that we can maybe highlight here. The first one would be a good communication first for the population, for the healthcare worker, like a risk communication. What is the disease? How we can do to prevent the disease? How we do for case management. The second one is how we can improve the detection, because we are seeing cases and we see that there are very sparse, I can say a few numbers of test kits that are available for the diagnostic. So we need to make sure that we have a good investigation team in the field to investigate cases, and also cases that are investigated are also are confirmed and diagnosed. So the other thing is how we can, for those who are sick, how we can provide a case management, as we show that there is no, for the moment, a specific treatment. So what kind of supportive care that we can use to take care of those patients? And for, to control the disease, we need a good preventive measure. The preventive measure will start with like a non-vaccine preventive measure first, to understand how disease is transmitted from one human to another, how in an area where we also see some zoonotic transmission, how the transmission is being is done in an area where we see kind of zoonotic transmission. And then we also have vaccines that are available, as we know that after the cessation of smallpox vaccination in 1980, most people born after we stopped the vaccination, I can say high risk of getting orthopox virus infection, and mostly Mpox. So meaning that we need to also provide a vaccine to increase the herd immunity in case, to be able to stop the chain of transmission and to limit the toll of mpox outbreak in the different countries. I don't know. I think Christy can comment on that also.
Well, I think you covered it really well. I think, what's important here is, as we've tried to outline, there's sort of different outbreaks depending on where you're looking in the country. And so the risk communication is probably going to differ if you're in the eastern part of DRC, where it's being spread mostly through sexual transmission in adults, and then in the western part, where you have more some zoonotic spillover, but likely household transmission that's occurring. And I think vaccine is a really an important part of disease prevention and control, but really sort of the basic infection prevention control measures. It's the same for clade 1 and clade 2. So in the US, for instance, we would recommend that the patient be isolated, that, if they're using any of the same material, that you avoid doing that and everything is disinfected before somebody else uses that bedding or food. Forks and knives, etc. So that's usually easy for us to do in the US, but in some of these very rural areas of the DRC, they might not have ways to isolate from their family members, and they might not have basic disinfection, material and hand soap and that sort of thing. So being able to provide that sort of material in addition to vaccine, I think, is just as critical. And again, tailoring the risk communication dependent on where you're working to make sure it's applicable. Both of the virus spread through close physical sustained contact. This is not a virus that generally spreads through, passing or sitting by somebody for brief periods. So it really needs to be focused on household transmission for parts of DRC, some zoonotic transmission, and then sexual transmission for other parts.
I'm going to kind of underscore that last point, because there's a lot of, I think, sort of uninformed commentary out there that this is spreading perhaps in ways very different from what you just described. A lot of people increasing fears that, this is going to turn up in kids' daycares all around the world. And anyway, that what you're describing to me sounds very different from that. So I just want to underscore that point for anyone who might be listening. That said, we want to kind of, be acknowledging of the particular patterns that we're seeing. But both of you described a situation to me when you hear that, as we increase surveillance for this virus, we start perhaps to find it in more places. And two, that waning immunity from, not being a long time since recent smallpox immunization may be contributing to why we're now starting to see more cases. When I put those two things together, to me, that sounds like mpox is probably going to be something that we have to think about for quite some time, and possibly think about it outside of traditional regions that we once worried about it. So I guess then the next thing is, what do we need for the kind of the larger, kind of more sustainable response? Obviously, there's a lot of interest in potentially using vaccines, and not enough access to vaccines in the places that need it, but also thinking that this could be a longer term challenge that I think underscores the importance of having more access to vaccines generally. Also interests in therapeutics, though I think the data that we've seen are a little bit mixed on that. Also, the role of supportive care and what supportive care means, and whether places can provide adequate supportive care, and then to do so safely, so to protect health workers that are involved in that care. So I'd love both of your thoughts on that kind of longer term. And then I'll turn it to, I see there's a bunch of questions in the Q&A box. Turn it to that. Maybe start with you, Dr. Mbala.
It's not you don't have easy questions. Jennifer.
This is not an easy problem. So, we're trying to further knowledge a little bit. We may not have all the answers. We can identify places where others, including, any researchers that are around that want to apply their skills, can help try to answer some of these questions. Sure.
Yeah, I think
the
fact, we have to also go back to the reality of the situation. Even when we talk about the vaccine, we have to be here, the fact that we'll not have enough doses of vaccine for everyone. So meaning that we need to make sure that we know for each situation, as Christy said, how we can, which strategy that we can use and how we can prioritize the population, the region that are more affected for which objective that we'd like to achieve. Do we need to stop human-to-human transmission? Do we need to maybe reduce the toll of severe cases? And so those are, what type of objective that we'd like to pursue. And the other thing that this, as Christy said, it's an old disease. We know, for example, how most of the zoonotic side of mpox is acquired in house setting. So with good communication and also sensitization of the community, we could be able at least to reduce, for example, the number of spillover, because then population, we can strengthen awareness of the community of the population, and this can help to reduce, for example, the spillover from wildlife to human. And at the human-to-human side, what we are seeing right now, it's also close contact. And now with the new dynamic, it's a sexual contact, meaning that there are also some complexity when we see like a key population involved, sex worker involved, meaning that there are some, I can say, more consideration for example, the HIV program and also other physician or clinician that are also involved following cases of like sexual transmissible diseases. So I think we need to make sure that we address the situation in the proper way. That can help, for example, before we reach to the vaccination, we can, by non-vaccination measure, limit at least some of, cases that can be avoided. And the other part would be the vaccination. As you said, after eradication of smallpox, the susceptible population is growing. So meaning that we will have to deal with mpox, maybe another orthopox virus in the future, and we will need to have vaccine available at least to prevent some of the transmission. So I think this is what I can say for the moment. I think Christy can also comment on that.
Yeah, that is a difficult question, and I think Placide really covered quite a bit of what I would say as well. I think making sure that going forward we develop strategies that are long lasting and not just sort of these short-term band-aid type fixes, because unlike smallpox, this is a zoonotic virus that has an animal reservoir or reservoirs, so it's not going to be likely that we're able to, eradicate monkeypox virus, unfortunately. So making sure we're using strategies that really focus on the groups at highest risk, both vaccination and infection prevention control, risk communication, et cetera. Making sure that, again, in the areas where it's spreading sexually, that we are building in strategies that are part of sort of the STI prevention, and making sure those clinicians are thinking about mpox, so that when they see somebody with that clinical presentation, they're doing the testing, and then helping to make sure their patient is informed on how to prevent spread to their family members, et cetera. Right now, there's not a specific therapeutic that we have approval for mpox. TPOXX, of course, has approval through the FDA animal rule for smallpox, and it's been used widely for mpox. The recent PALM study in the DRC at this point doesn't show a positive effect of that drug. But really what was informative, there were many informative things from that study, but one thing that came out is that, again, providing basic supportive care such as pain relief, fluids, adequate food, really went a long way in improving the patient outcome. So that's something that's tangible that can be done. Hopefully, although of course there's a lot of challenges with doing that out again in some of these very rural parts of the DRC. And then finally, the last point is, on testing, which, as Placide mentioned, is such an important part, and because there are other rash-causing illnesses in the DRC that can get confused with Mpox. We've seen that both in this current outbreak and in past outbreaks. But testing isn't always possible at the percentage we see in the US or in other countries. So making sure that we have really well-trained surveillance workers that have a good sense of what the clinical presentation looks like, and perhaps test a percentage of a family that has an Mpox-like illness, for instance, rather than all of those family members. So developing those sorts of strategies with the country input, making sure they're comfortable with that, so that we can actually maintain good surveillance paired with reasonable, sustainable testing, I think is going to be really important.
Great. So I'm going to try to look through these questions that are in the Q&A box, and encourage our guests to also look and see if there are particular ones you want to answer. But maybe I'll just start because I might kind of condense a few of them so we can get them. One is talking about children. And I think that the occurrence of children in the most recent cases, I think, felt different than what we were seeing in 2022. And I know, Dr. Mbala, you kind of talked a little bit about this, but maybe if you could offer more thoughts specifically on why there are more pediatric cases in the most recent occurring now, and if that points to any particular difference in strategy needed in terms of protecting children.
Yeah, what you can do, um, uh, type of strategy to protect children, I think first is to understand how they are getting contaminated. And it's a big question because we suppose that, okay, for where we are seeing like zoonotic transmission, they are directly in contact with small mammals, because in our culture in some rural area, children are used to hunt small mammals, so they can get infected directly from wildlife, but also they get infected by close contact with another person infected in the same household. So first of all is a good communication to the parents to explain how it could be possible in a rural area where children are at a risk to get contaminated by wild animals, how they can, prevent this transmission. This is the first one. The second one is when there is someone infected in the household, how quickly they can isolate this person to avoid any close or contact with the other family member. But we can say, Christy can comment on that, it's very difficult because when you are in a rural area, for example, when you talk about a quarantine, how you can do that in a household where you have only, for example, 1 or 2 rooms with, many people living together. So it's a big question and sometimes difficult to do. The other things that we need to understand, it's also still a big question, is where we are seeing more human-to-human transmission with through sexual activities, how we are seeing this shift from a young adolescent to small children affected. So, what how the transmission of these small children is driven is still a big question. We think that it could be by close contact, but how we are having more and more children affected, where we used to see at the beginning of the outbreak more young adults affected. So I think it's a big question, and the role is for adult and young adult to protect the children who are living in the same household. And this, no, I think for me, it's really the role of a good risk communication that should be tailored according to the different place and the different clade, the different situation, and to also strengthen our awareness of our community.
I keep asking about children in part because a lot of the infrastructure that countries built in 2022 was really geared towards this being transmitted sexually, and that involved providers and risk communication plans. That's very different from what you would need if this were affecting a larger portion of the population. Based on what you're describing to me, that doesn't seem like the kind of transmission we would see in other settings, but I think it does raise some questions about whether we need plans that involve other providers. For instance, do pediatricians need to know about this virus and what it looks like, et cetera? So you're shaking your head, Dr. Hudson. I'd love to hear your thoughts on this.
Yeah. So I'll just add, I saw one of the questions, but historically in the DRC, those under 15 are always the most impacted. So this is not new. This has always been the demographic that we see the most cases in within the DRC. And probably that's, multiple factors. They don't have any immunity. They're also, as Placide just mentioned, the ones that probably have the most wildlife interactions. And so that's contributing. And then also, of course, if there are underlying health conditions, particularly food insecurity, which in Ecuador, that's a really big problem there. The kids are going to have more severe disease, and that's who's going to go and, seek testing and treatment potentially if they're more severe. So just to point out that this is not new for this country, the South Kivu and the sexual transmission in adults is sort of a new situation and picture, but not the children. And then as far as who we should be concerned about, this virus, as I know I've said this multiple times, but it's not an aerosol or respiratory type virus. You do have to have that close contact. Sexual transmission happens to be very good at transmitting it. So unfortunately in 2022, within MSM networks, it really was very efficient at transmitting, and we saw sustained human-to-human transmission, which we had previously not really seen. And then in the current outbreak, again, it's a lot in sex trade workers, including female sex trade workers. So more heterosexual transmission, although still data missing on some of the epi drivers. But for the US, we've done some modeling, and we really pushed the envelope. So we bumped up the secondary attack rate to 30%, which is more than double what we see in country. And it really demonstrated that in households, including in children, you would not see sustained spread. You would see small clusters, less than 10 cases. So again, trying to compare, as Placide just outlined, what a household looks like in these rural parts of DRC where we're seeing household spread compared to a US household, I think is really, I don't even know if apples to oranges is a good analogy. It's like apples to watermelons or something. So I just don't think that comparison makes sense.
A question here about waning immunity and whether there's studies looking at the length of immunity. And then I guess if we could extend this to the most recent vaccination efforts and whether there are concerns about the protection offered if you recently got vaccinated in the last few years whether you're protected going forward. And if you share a thought, latest thinking, I realize this may be an open scientific question, but what do we know so far? Either of you who would
Sorry,
like to answer.
Jennifer, I didn't get your question. Sorry.
The question's about
Can you
waning
come-
immunity and if there are studies looking at the length of immunity. So I think the first comment had been about, well, we're not vaccinating for smallpox anymore. We stopped that in decades ago. But do we know for how long people may be protected, not just from prior smallpox vaccination, but also, I guess, more recently, for people who did get vaccinated against Mpox specifically, what the thought of for how long they may be protected, or any role that waning immunity could play?
I think what I can say, maybe, I think Christy will comment on that also. There is one study that we conducted in DRC from 2002, 2007. It was mostly to understand, the epidemiology of Mpox in DRC. After we saw a huge outbreak in 96, 97. So then we found out that the incidence was very high in DRC compared to what was reported in 81, 86 by WHO. And also we assess the long-term immunity among people vaccinated from smallpox in late I can say 70, because the vaccination stopped in the country in DRC around 77. So we assess the vaccine. So it was about, I can say, 30, 20 years later. So we found out that those people vaccinated against smallpox were kind of protected around like 80%. So close to 85% reported by the CDCs. And also there are a few studies that are being conducted, I think, in Netherlands, where they compare, for example, neutralizing antibody among people vaccinated against smallpox previously and people vaccinated against the Jynneos, and they see kind of a very good level of neutralizing antibody among those people vaccinated previously against smallpox. So we think that this vaccine still protect, but as we know that it has been many years after vaccination, so probably there could be some waning immunity, and not only waning immunity among people vaccinated, but also waning herd immunity, because we have more susceptible population, like a growing number of susceptible population compared to people vaccinated before against smallpox. Yeah. Okay, safe. Yeah.
Yeah. I'll just add, so for Jynneos, we've done some, we started a study with DRC collaborators in 2017 in the Chuapa province, vaccinated healthcare workers. And it's not a clinical study, so there's no non-vaccinated arm, but it does show good efficacy in a group that has a relatively high risk of clade 1 infection, and thus far I believe there's only been one breakthrough infection. And interestingly, from that study, we've actually gone back and done boosters, and we see even those participants that basically were back almost at baseline according to their antibody titers. When we gave the boost at 5 years and even 7 years post-primary, we saw a very strong anamnestic response right after the boost. So it does show that those memory cells are remembering the vaccine and would likely respond quickly to an infection. So that information, and then the ongoing VE studies in the US, including we do epi surveillance data, and recently published an MMWR showing that in those that received 2 doses in the US, less than 1% have had breakthrough infections as of May of 2024. So, limited number of participants, but it does suggest that Jynneos continues to perform 2 years after at least. And then our DRC study supports that as far as 7 years after there's a strong memory response.
I'm going to insert my own question here. Apologies to those who are waiting to get their question answered, but we haven't really talked much about testing and what testing needs are necessary. If you have any areas where you think testing needs to be enhanced, do we need a clade-specific test that's easily available? If there's concerns about difference in severity, one could imagine that could prompt a different level of clinical or different course of clinical care. And so what kinds of testing would you like to see happen? Or tests developed? What's on your wish list of testing?
Yeah, I can. Yeah, I think we know that these outbreaks are occurring in a rural area where sometimes there is no electricity, there is no running water. The road infrastructure can be also very difficult. So meaning that we need at least to have a test that can be easy to use, like a rapid test, like a point of care, because having like a qPCR everywhere will be almost impossible. And also we need to think about the cost, because as you know, now we are having some point of care, but sometimes the cost of those point of care and the reagent are not really, I can say, affordable. So it would be difficult to sustain the diagnostic using those some of our point of care. So we think that like a rapid test could be also a solution for screening at like a very remote rural area, and have like confirmation with PCR in a big city and so on. This is first thing. And also we are also doing genotyping to also understand and assess the evolution of the virus that we are seeing, as we are now describing clade 1A, clade 1B, but we know already that within clade 1A, there are some subclades that are sometimes a bit different from one region to another. And we believe that maybe we may also see the same thing as we with clade 1B, as we observe with the clade 2B, where we are seeing also some like a subclade or different variants that can emerge. So I think this is, a different step where we can go. So having something that can be suitable for rural area, but also having some, I can say, a more sophisticated diagnostic capacity in like a big city, big lab. Yeah, in more, I can say, where people are more experienced and are more trained.
And can I just ask you, in case there's any enterprising test developers listening, are there particular specimen types that you could have your perfect rapid test for operational requirements?
Yeah, according to what we know about the disease, we prioritize oral swab and skin lesions, because we know that viral load in blood, viremia, it does need to really last longer, and usually when the patient arrives at the hospital, they have already spent some time in the village, so meaning that the chance to get the virus in the blood is very low. But at the same time, we still have the chance to have the virus in saliva or oral swab, and also if the patient has already skin lesion, and it would be preferable to collect skin lesions.
Dr. Hassan, maybe if I could add to that question, anything else you want to say about testing, and particularly maybe if we need clade-specific testing, and then also we haven't really talked about wastewater and
Sure.
the role that plays.
Yeah, no, I think for me, what is most important is just making sure that the test being used is accurate at identifying mpox. So that way you can start infection prevention control and messaging needed so they can protect themselves and others. Both in the DRC and the US, the clinical care is really based on that person's presentation. It's not based on the clade, and particularly in the US, there would be no difference in clinical treatment for clade 1 versus clade 2. It depends on what that person's presentation is that would dictate how their clinical care is done. So I think that making sure the test is accurate for detecting mpox, and then particularly in remote settings, as Placide mentioned, having a test that can be used either, maybe it has a battery backup so that the run can continue if electricity is interrupted, et cetera, and then sending at least a subset to the INRB Kinshasa National Lab to do sequencing to monitor for mutations and what clade is spreading, is important for outbreak control, but not for patient care would be my recommendation.
We only have a few minutes left, and I almost hate to ask what I think will be the last question to you both, which is any other viruses on your watch list? There's a few questions here about what other orthopox viruses you may be paying attention to, but anything else we should see?
No. So, my knowledge,
Okay.
in my knowledge, mpox still, I can say, the more susceptible virus to be, easily transmitted, either from wildlife to human and also from human to human. Other orthopox virus can somehow be transmitted to human, but we have never reported any case of human to human transmission. So I think for the moment we pay more attention to mpox, but we still keep an eye on other orthopox viruses like cowpox that we don't see in our area, but for the moment we don't have any evidence of like a human to human transmission. So for the moment, I think it's only mpox, which is able to go from wildlife to human and human to.
And just maybe quickly, because someone put it in there, have you seen co-infection with the two clades?
Yes. Co-infection.
Yes.
Oh, sorry. Co-infection in one
With the two.
patient with clade? No.
Yeah.
We see a co-circulation of the virus clade 1, clade 2, sorry, clade 1A, clade 1B in Kinshasa, but we have not seen yet like co-infection in one patient with the two clade, not yet. I don't have any evidence of that yet.
And Dr. Hudson, I didn't give you a chance to say what other viruses we should be paying attention to.
No, I agreed with Placide. I mean, we know there are other like cowpox, vaccinia, boreal pox, was Alaska pox, that occasionally we see severe infection in people that are immunocompromised, but like Placide mentioned, not human to human transmission and not severe infection in those that are immunocompetent.
That's great. I'm not eager to add anything to the watch list. Thank you both. Really, this has been incredibly informative. I really thank you both for your time, but also just sharing some, I think, really incredibly important knowledge that for me actually makes me feel that we have much more of a sense of what's going on. I think there were a lot of questions in there about the levels of resources that are available, and I think that is an important question that we should continue. But for right now, getting down kind of this critical information that points to the operational response that's needed is really, really helpful. So I'd like to thank you both for just your time and also just your continued work on these issues. Really very helpful. Thank you for sharing your insights with us. I'd also like to thank my team at the Pandemic Center who helped put this event together: Bentley Holt, Michael Mitchell, Leah Lovgren, Amanda Kogan, Carly Gaska, Andrea Ulig, Ann Wang, and Alice Im. And thanks to all who tuned in. If you'd like to share this event with anyone who's unable to attend, the recording will be posted on the events page of our website next week. You can also find recordings of our previous webinars there. And if you follow our social media accounts, the handles are on the screen now, you can stay informed about when we post that and also what our future webinars are. And if anyone has any additional questions, particularly if we failed to cover a very salient question here, I'd appreciate if you reach out to our email address. And also feel free to send along any suggestions for future webinars. And with that, we're adjourned. Be safe, be healthy, stay engaged. Thank you.